Question 1. A nurse is caring for a patient experiencing septic shock. Which of the following hemodynamic parameters is the most appropriate initial goal for mean arterial pressure, MAP? A. MAP greater than 55 mm of mercury. B. MAP greater than 60 mm of mercury. C. MAP greater than 65 mm of mercury. D. MAP greater than 70 mm of mercury. Answer, C. MAP greater than 65 mm of mercury. This question tests knowledge of hemodynamic goals in septic shock, with initial goal being a key phrase directing you to the standard recommendation. Maintaining a mean arterial pressure, MAP, greater than 65 mm of mercury is crucial to ensure adequate organ perfusion and prevent ischemic injury in patients with sepsis. This target helps maintain blood flow to vital organs like the kidneys, brain, and heart, which are highly susceptible to damage during states of hypoperfusion. For instance, if a patient's MAP drops below 65 mm of mercury, the nurse would prioritize interventions such as fluid resuscitation or vasopressor administration to reach this goal. Always remember that a MAP of 65 mm of mercury or greater is the widely accepted minimum for preserving organ function in critically ill patients. Question 2. A patient in the ICU has the following arterial blood gas, ABG, results, pH 7, 28, PaCO2 55 mm of mercury, HCO3 24 milliequivalent/L, PAO2 88 mm of mercury. What is the primary acid-base disturbance? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Respiratory alkalosis. Answer, C. Respiratory acidosis. This question assesses your ability to interpret ABG results, and the key clue is the combination of a low pH, acidity, and an elevated PaCO2, which represents the respiratory component. A pH of 7, 28 indicates acidosis, and a PaCO2 of 55 mm of mercury, normal range is 35 to 45 mm of mercury, indicates respiratory retention of carbon dioxide. Since the bicarbonate, HCO3, is within the normal range, there is no significant metabolic compensation or primary metabolic disturbance. For example, conditions like hypoventilation due to opioid overdose or severe COPD exacerbation can lead to these ABG findings. Always associate a low pH with a high PaCO2 as primary respiratory acidosis, meaning the lungs are not effectively eliminating CO2. Question 3. A nurse is reviewing lab results for a patient receiving continuous renal replacement therapy, CRRT. The patient's potassium level is 2, 9 milliequivalent/L. Which electrocardiogram, ECG, change would the nurse most likely expect to see? A. Tall, peak T waves. B. Prolonged PR interval. C. Shortened QT interval. D. Prominent U waves. Answer, D. Prominent U waves. This question evaluates your understanding of electrolyte imbalances and their cardiac manifestations, specifically focusing on hypokalemia given the low potassium level. Hypokalemia, a potassium level below 3, 5 milliequivalent/L, is associated with various ECG changes, including flattened T waves and the appearance of prominent U waves. Tall, peak T waves are indicative of hyperkalemia, not hypokalemia. Recognizing prominent U waves on an ECG can be a critical clue to identifying dangerously low potassium levels in a patient. Remember, U4 under, low potassium, often helps link prominent U waves with hypokalemia. Question 4. A patient with a severe traumatic brain injury develops increasing intracranial pressure, ICP. Which of the following nursing interventions is most appropriate to help reduce ICP? A. Encourage coughing and deep breathing exercises. B. Position the head of the bed flat. C. Administer prescribed mannitol. D. Perform frequent suctioning. Answer: C. Administer prescribed mannitol. This question focuses on critical interventions for managing elevated intracranial pressure, with reduced ICP being the direct cue. Administering mannitol, an osmotic diuretic, is a primary pharmacological intervention used to decrease cerebral edema and thus lower ICP by drawing fluid from the brain tissue into the vascular space. Encouraging coughing, positioning the head of the bed flat, and frequent suctioning can all increase ICP and should be avoided or performed cautiously. For instance, if a patient's ICP monitor shows a sustained elevation above 20 millimeters of mercury, mannitol might be ordered as a rapid-acting intervention. Always prioritize interventions that directly reduce brain volume or fluid when dealing with elevated ICP. Question 5. A patient presents to the emergency department with crushing chest pain, diaphoresis, and ST segment elevation in leads 2, 3, and AVF on the electrocardiogram. Which type of myocardial infarction is indicated by these findings? A. Lateral wall MI. B. Anterior wall MI. C. Inferior wall MI. D. Septal wall MI. Answer: C. Inferior wall MI. This question assesses your ability to localize a myocardial infarction based on ECG changes, specifically focusing on ST segment elevation. ST segment elevation in leads 2, 3, and AVF is characteristic of an inferior wall myocardial infarction, which typically involves the right coronary artery. Lateral wall MIs involve leads I, AVL, V5, V6, anterior wall MIs involve leads V2, V4, and septal wall MIs involve leads V1, V2. For example, knowing these lead groupings helps the nurse anticipate potential complications, such as bradycardia and heart blocks often seen with inferior MIs due to involvement of the right coronary artery, which supplies the AV node. Always connect specific ECG leads with the corresponding area of the heart to quickly identify the location of the MI. Question 6. A 45-year-old patient with type 1 diabetes is admitted with diabetic ketoacidosis, DKA. The nurse anticipates orders for which primary initial fluid resuscitation solution? A. Dextrose 5% in water, D5W. B. 0.45% sodium chloride, half normal saline. C. 0.9% sodium chloride, normal saline. D. Lactated Ringer's solution. Answer: C. 0.9% sodium chloride, normal saline. This question tests your knowledge of initial management for diabetic ketoacidosis, with primary initial fluid resuscitation being the key phrase. In DKA, patients are severely dehydrated, and the primary initial fluid of choice is isotonic 0.9% sodium chloride, normal saline, to rapidly restore circulating volume and improve tissue perfusion. Hypotonic solutions like 0.45% sodium chloride are usually initiated after initial resuscitation, and D5W is typically used when blood glucose levels approach normal to prevent hypoglycemia. For example, a patient presenting with hypotension and tachycardia in DKA would receive rapid infusions of normal saline to stabilize hemodynamics. Remember that restoring fluid volume with normal saline is the critical first step in DKA management before addressing glucose and electrolyte imbalances. Question 7. A patient with acute kidney injury, AKI, has a GFR of 15 ml/min/1, 73 m superscript 2 and is experiencing fluid overload unresponsive to diuretics. The nurse anticipates which renal replacement therapy? A. Peritoneal dialysis. B. Hemodialysis. C. Continuous renal replacement therapy, CRRT. D. Plasmapheresis. Answer, B. Hemodialysis. This question assesses your understanding of indications for renal replacement therapy in acute kidney injury, with fluid overload unresponsive to diuretics and a very low GFR indicating a severe need. Hemodialysis is the most common and effective method for rapidly removing fluid and solutes in acute kidney injury when conservative management fails, particularly in cases of severe fluid overload or electrolyte imbalances. Peritoneal dialysis is less common in acute settings and requires a functional peritoneum, while CRRT is typically used for hemodynamically unstable patients who cannot tolerate the rapid fluid shifts of conventional hemodialysis. For instance, if a patient developed pulmonary edema from fluid overload due to AKI, emergent hemodialysis would be the intervention of choice. Remember, hemodialysis provides rapid and efficient removal of toxins and fluid in critical AKI. Question 8. A nurse is assessing a patient admitted with severe sepsis. Which finding is the most indicative of early septic shock? A. Hypotension unresponsive to fluid resuscitation. B. Warm, flushed skin and bounding pulses. C. Bradycardia and hypothermia. D. Pulmonary edema and crackles. Answer, B. Warm, flushed skin and bounding pulses. This question focuses on recognizing the early signs of septic shock, often referred to as warm shock, which is a crucial concept in critical care. In the early hyperdynamic phase of septic shock, patients often exhibit warm, flushed skin, bounding peripheral pulses, and a wide pulse pressure due to peripheral vasodilation. Hypotension unresponsive to fluids is characteristic of late or refractory septic shock. Bradycardia and hypothermia are not typical early signs, and pulmonary edema, while possible, is not the most indicative initial finding of the shock state itself. For example, a patient might present with a fever, confusion, and feel unusually warm to the touch despite having an infection, signaling early septic shock. Always remember that early septic shock can manifest as a warm presentation due to the body's initial compensatory vasodilation. Question 9. A patient with acute pancreatitis develops severe abdominal pain, nausea, and vomiting. The nurse understands that which laboratory finding is most specific to acute pancreatitis? A. Elevated C-reactive protein, CRP. B. Elevated serum amylase. C. Elevated serum lipase. D. Elevated white blood cell count, WBC. Answer, C. Elevated serum lipase. This question tests your knowledge of diagnostic markers for acute pancreatitis, with most specific being the key identifier. While serum amylase and white blood cell count can be elevated in pancreatitis, serum lipase is considered more specific to pancreatic inflammation and remains elevated for a longer duration than amylase. An elevated C-reactive protein is a general marker of inflammation and not specific to pancreatitis. For example, if a patient presents with classic pancreatitis symptoms, a significantly elevated serum lipase level would strongly confirm the diagnosis. Always remember that serum lipase is the gold standard lab test for confirming acute pancreatitis because of its specificity to the pancreas. Question 10. A critically ill patient's family requests that all life-sustaining treatments be withdrawn. The patient had previously expressed a desire for aggressive treatment, but is now intubated and unable to communicate. The nurse's primary ethical obligation in this situation is to A. Support the family's decision, as they are next of kin. B. Follow the patient's previously expressed wishes. C. Contact the hospital's ethics committee for guidance. D. Encourage the family to reconsider their request. Answer B. Follow the patient's previously expressed wishes. This question addresses a core ethical principle in critical care: patient autonomy, especially when the patient's wishes conflict with family desires. When a patient has clearly expressed their wishes regarding medical treatment, even if they are now incapacitated, their previously stated autonomy takes precedence over the family's requests, unless there is a formal advance directive like a durable power of attorney for healthcare that designates someone else to make decisions. While contacting the ethics committee, C, is a good step if conflict persists, the initial ethical obligation is to honor the patient's known preferences. For instance, if a patient had a living will stating they desired aggressive treatment, that document guides care. Remember, the patient's voice, even when silent, holds the most weight in ethical decision-making regarding their own care. Question 11. A patient with sepsis develops widespread petechiae, purpura, and bleeding from intravenous sites, along with a significant drop in platelet count and elevated D-dimer. These findings are most consistent with which condition? A. Idiopathic thrombocytopenic purpura, IDP. B. Thrombotic thrombocytopenic purpura, TTP. C. Disseminated intravascular coagulation, DIC. D. Heparin-induced thrombocytopenia, HIT. Answer C. Disseminated intravascular coagulation, DIC. This question describes a classic presentation of disseminated intravascular coagulation, DIC, an important hematologic disorder in critical care, with widespread bleeding, drop in platelet count, and elevated D-dimer being crucial indicators. DIC is characterized by widespread activation of the clotting cascade, leading to microthrombi formation throughout the body, which then consumes clotting factors and platelets, resulting in simultaneous bleeding and clotting. IDP and TTP primarily involve platelet destruction or aggregation, and HIT is specific to heparin exposure, none of which fully explain the widespread clotting and bleeding alongside elevated D-dimer. For example, a patient with severe sepsis who suddenly starts oozing blood from every puncture site and has rapidly declining clotting factors is likely experiencing DIC. Always recognize DIC as a paradoxical condition involving both excessive clotting and bleeding. Question 12. A patient on mechanical ventilation for ARDS has an alarm indicating high peak inspiratory pressure. After assessing the patient and ensuring tubing patency, which action should the nurse perform next? A. Increase the fraction of inspired oxygen, FiO2. B. Administer a sedative or neuromuscular blocking agent. C. Check for kinks in the tubing or patient biting the ETT. D. Decrease the positive end expiratory pressure, PEEP. Answer C. Check for kinks in the tubing or patient biting the ETT. This question focuses on troubleshooting high peak inspiratory pressure, PIP, alarms on a mechanical ventilator, a common scenario in critical care. A high PIP alarm indicates increased resistance to airflow or decreased lung compliance, and the initial step after checking the patient and general circuit should be to look for easily correctable mechanical issues. Kinks in the tubing or the patient biting the endotracheal tube, ETT, are common causes of increased airway resistance that can be quickly resolved. Administering sedatives or adjusting PEEP might be necessary later but are not the immediate next step after basic assessment. For instance, if the patient is restless and appears to be chewing on the ETT, a bite block or gentle sedation might be considered after checking for kinks. Always systematically check for mechanical obstructions first when a high PIP alarm sounds. Question 13. A patient's arterial blood gas, ABG, results are pH 7, 32, PaCO2 50 mm of mercury, HCO3 28 milliequivalent/L. What is the acid-base disorder, including compensation? A. Uncompensated respiratory acidosis. B. Partially compensated respiratory acidosis. C. Fully compensated respiratory acidosis. D. Uncompensated metabolic alkalosis. Answer B. Partially compensated respiratory acidosis. This question requires a comprehensive interpretation of ABG results, including identifying compensation. The pH is acidic, 7, 32, indicating acidosis. The PaCO2 is elevated, 50 mmHg, suggesting a respiratory problem. The HCO3 is also elevated, 28 milliequivalent/L, normal 22 to 26 milliequivalent/L, indicating that the kidneys are attempting to compensate by retaining bicarbonate. Since the pH is still abnormal, not returned to normal range, the compensation is partial. For example, a patient with chronic obstructive pulmonary disease might have these ABG values as their body attempts to manage long-term CO2 retention. Remember to evaluate all three values, pH, PaCO2, and HCO3, to determine the primary disorder and the degree of compensation. Question 14. A nurse is caring for a patient experiencing ventricular fibrillation, VF. What is the immediate priority intervention? A. Administer amiodarone intravenously. B. Prepare for synchronized cardioversion. C. Initiate cardiopulmonary resuscitation, CPR, and defibrillation. D. Obtain a 12-lead electrocardiogram. Answer C. Initiate cardiopulmonary resuscitation, CPR, and defibrillation. This question tests your knowledge of the immediate management of a life-threatening arrhythmia, ventricular fibrillation. Ventricular fibrillation is a pulseless cardiac arrest rhythm, and the immediate priority is high-quality cardiopulmonary resuscitation, CPR, followed by rapid defibrillation, as outlined by Advanced Cardiac Life Support, ACLS, guidelines. Amiodarone is an antiarrhythmic medication given after initial defibrillation attempts, and synchronized cardioversion is used for tachyarrhythmias with a pulse. Obtaining a 12-lead ECG is not an immediate action during an active cardiac arrest. For example, if the monitor shows VF, the nurse should immediately call for help, start chest compressions, and prepare the defibrillator. Always remember that for pulseless VF, shock first is the guiding principle after initiating CPR. Question 15. A patient with severe hyponatremia, serum sodium 118 milliequivalent/L, is experiencing seizures. The nurse anticipates the administration of which intravenous fluid? A. 0.45% sodium chloride. B. Dextrose 5% in water, D5W. C. 3% sodium chloride. D. Lactated Ringer's solution. Answer C. 3% sodium chloride. This question assesses your understanding of critical interventions for severe, symptomatic hyponatremia, especially when neurological symptoms like seizures are present. For severe, symptomatic hyponatremia, serum sodium typically below 120 milliequivalent/L, accompanied by neurological manifestations, hypertonic saline, e.g., 3% sodium chloride, is administered cautiously to rapidly, but not excessively, raise the serum sodium level and prevent cerebral edema. Hypotonic solutions, 0.45% sodium chloride, D5W, would worsen hyponatremia, and lactated ringers is isotonic but not sufficient to acutely correct severe sodium deficits. For instance, a patient having seizures due to severe hyponatremia requires a rapid, controlled increase in sodium, making hypertonic saline the appropriate choice. Remember that 3% sodium chloride is reserved for life-threatening hyponatremia and must be administered with extreme caution to avoid overcorrection. Question 16. A patient is admitted with an acute ischemic stroke. Which medication is contraindicated if the patient's blood pressure is 190/110 mmHg and they are not a candidate for thrombolytic therapy? A. Aspirin. B. Labetalol. C. Enoxaparin. D. Tissue plasminogen activator, TPA. Answer, D. Tissue plasminogen activator, TPA. This question targets your knowledge of contraindications for thrombolytic therapy in ischemic stroke, with the key clue being the high blood pressure and the explicit statement, not a candidate for thrombolytic therapy, though the blood pressure itself is a major contraindication. Tissue plasminogen activator, TPA, is a potent thrombolytic drug used for acute ischemic stroke, but it has strict blood pressure parameters. A systolic BP greater than 185 mm of mercury or diastolic BP greater than 110 mm of mercury is a contraindication to its administration due to increased risk of hemorrhagic transformation. Aspirin and enoxaparin, a low molecular weight heparin, are often used in stroke management but not as an acute thrombolytic. Labetalol is an antihypertensive that might be used to control blood pressure in this scenario. For example, if a patient arrived with an ischemic stroke and their BP was 195/105, TPA would be withheld. Always remember that tight blood pressure control is paramount before considering TPA due to the high risk of intracranial hemorrhage. Question 17. The nurse notes a central venous pressure, CVP, reading of 2 mm of mercury in a critically ill patient. This finding most likely indicates A. Fluid overload. B. Right ventricular failure. C. Hypovolemia. D. Pulmonary hypertension. Answer, C. Hypovolemia. This question assesses your understanding of central venous pressure, CVP, and its clinical significance, particularly low readings. A normal CVP ranges from 2 to 6 mm of mercury, and a CVP reading of 2 mm of mercury or less typically indicates hypovolemia, low circulating blood volume, due to conditions like dehydration, hemorrhage, or excessive diuresis. Fluid overload and right ventricular failure would lead to an elevated CVP, as would pulmonary hypertension, which increases the workload on the right ventricle. For example, a patient with a CVP of 2 mm of mercury might also exhibit signs of dehydration such as dry mucous membranes and poor skin turgor. Remember that a low CVP often signals the need for fluid resuscitation to improve preload. Question 18. A patient is admitted with syndrome of inappropriate antidiuretic hormone, SIAD. The nurse expects to see which combination of laboratory findings? A. High serum sodium, low urine osmolality. B. Low serum sodium, high urine osmolality. C. High serum sodium, high urine osmolality. D. Low serum sodium, low urine osmolality. Answer, B. Low serum sodium, high urine osmolality. This question tests your knowledge of the characteristic laboratory findings in syndrome of inappropriate antidiuretic hormone, SIAD, which involves excessive release of ADH. In SIADH, too much ADH causes the body to retain water, leading to dilutional hyponatremia, low serum sodium, and concentrated urine, high urine osmolality, as the kidneys continue to excrete sodium in a relatively small volume of highly concentrated urine. The excess water dilutes the blood, while the kidneys continue to conserve water. For instance, a patient with lung cancer might develop SIADH, presenting with symptoms of hyponatremia and lab work reflecting concentrated urine despite low serum sodium. Always link SIAD with too much water, too much ADH leading to a low serum sodium and concentrated urine. Question 19. A patient is receiving continuous renal replacement therapy, CRRT. The nurse observes the effluent, drainage, is dark red and cloudy. What is the most immediate nursing action? A. Increase the blood flow rate. B. Administer an anticoagulant. C. Notify the primary care provider. D. Flush the CRRT circuit with normal saline. Answer: C. Notify the primary care provider. This question focuses on recognizing and responding to critical complications during continuous renal replacement therapy, CRRT. Dark red and cloudy effluent from a CRRT circuit is a significant and concerning finding, potentially indicating blood in the circuit, hemolysis, or infection, which warrants immediate medical evaluation. While increasing blood flow or flushing might be considered in other scenarios, these actions are inappropriate and potentially dangerous without understanding the cause of the discolored effluent. Administering an anticoagulant might worsen bleeding if hemolysis is the cause. For example, if the effluent turns dark red, this could mean red blood cells are being damaged in the filter, requiring prompt assessment and intervention by the care team. Always report any alarming changes in CRRT effluent immediately to the provider. Question 20. A patient in the intensive care unit, ICU, develops acute respiratory distress syndrome, ARDS, disseminated intravascular coagulation, DIC, and acute kidney injury, AKI, following severe sepsis. This combination of organ dysfunction is most indicative of A. Systemic inflammatory response syndrome, SIRS. B. Sepsis-induced organ failure. C. Multiple organ dysfunction syndrome, MODS. D. Compensated shock. Answer: C. Multiple organ dysfunction syndrome, MODS. This question assesses your understanding of the progression of critical illness, particularly the definition of multiple organ dysfunction syndrome. The development of severe dysfunction in two or more organ systems, respiratory, hematologic, renal in this case, in a critically ill patient, especially as a consequence of sepsis, is the hallmark of multiple organ dysfunction syndrome, MODS. Systemic inflammatory response syndrome, SIRS, is a broader inflammatory response, and while sepsis-induced organ failure is a component, MODS specifically refers to the multiple organ systems failing. Compensated shock implies the body is still maintaining function, which is not the case here. For instance, a patient who initially had sepsis and then progressed to needing a ventilator for ARDS, CRRT for AKI, and developed DIC is clearly experiencing MODS. Always recognize that MODS involves the failure of multiple vital organ systems due to a severe insult. Question 21. A nurse is assessing a patient with a suspected deep vein thrombosis, DVT, in the lower extremity. Which assessment finding requires immediate nursing intervention due to potential for life-threatening complications? A. Calf pain with dorsiflexion of the foot, Holman's sign. B. Unilateral leg swelling and warmth. C. Sudden onset of dyspnea and chest pain. D. A palpable cord along the vein. Answer: C. Sudden onset of dyspnea and chest pain. This question focuses on recognizing life-threatening complications of DVT, specifically a pulmonary embolism. While calf pain, unilateral swelling, warmth, and a palpable cord are all signs of a DVT, the sudden onset of dyspnea, shortness of breath, and chest pain are classic symptoms of a pulmonary embolism, PE, which occurs when a part of the DVT breaks off and travels to the lungs. A PE is a medical emergency requiring immediate intervention. For example, if a patient with a DVT suddenly becomes acutely short of breath, the nurse must suspect a PE and immediately initiate emergency protocols. Always prioritize respiratory distress and chest pain in a patient with a suspected DVT, as these indicate a potentially fatal pulmonary embolism. Question 22. A patient with a history of chronic heart failure presents with increasing dyspnea, orthopnea, and bilateral crackles in the lungs. The nurse anticipates an order for which medication to reduce preload? A. Dobutamine. B. Furosemide. C. Digoxin. D. Enalapril. Answer B. Furosemide. This question assesses your understanding of acute heart failure management, specifically interventions to reduce preload. Furosemide, a loop diuretic, is a primary medication used to reduce fluid volume and thus decrease preload in patients with heart failure experiencing fluid overload symptoms like dyspnea and crackles. Dobutamine is an inotrope that increases contractility, digoxin is used to improve contractility and slow heart rate, and enalapril is an ACE inhibitor that reduces afterload and preload, but furosemide offers the most immediate reduction in fluid volume. For example, a patient with acutely decompensated heart failure and pulmonary edema would likely receive intravenous furosemide to quickly remove excess fluid. Always remember that diuretics like furosemide are essential for managing fluid overload and reducing preload in heart failure exacerbations. Question 23. A patient with a severe upper gastrointestinal bleed has a hemoglobin of 6.8 g/dl and is hypotensive. After initiating intravenous fluids, the nurse anticipates the administration of which product? A. Platelets. B. Fresh frozen plasma, FFP. C. Packed red blood cells, PRBCs. D. Cryoprecipitate. Answer C. Packed red blood cells, PRBCs. This question focuses on the immediate management of a severe gastrointestinal bleed with significant blood loss. A hemoglobin of 6.8 g/dl indicates severe anemia due to blood loss, and hypotension suggests hypovolemic shock. Administering packed red blood cells, PRBCs, is the most appropriate intervention to rapidly restore oxygen carrying capacity and circulating volume. Platelets are given for thrombocytopenia, FFP for coagulopathy, and cryoprecipitate for specific clotting factor deficiencies, which are not the primary, immediate need for severe anemia from hemorrhage. For instance, a patient actively bleeding from an ulcer who is hypotensive needs blood transfusions to stabilize their condition. Always prioritize transfusing packed red blood cells to address severe anemia and hypovolemia in acute hemorrhage. Question 24. A patient post-myocardial infarction suddenly develops acute, severe mitral regurgitation. The nurse should be most concerned about the development of which complication? A. Ventricular septal defect. B. Cardiogenic shock. C. Pericarditis. D. Atrial fibrillation. Answer B. Cardiogenic shock. This question addresses a serious and often rapidly fatal mechanical complication of myocardial infarction. Acute, severe mitral regurgitation post-MI, usually due to papillary muscle rupture or dysfunction, can lead to a sudden increase in left atrial pressure and pulmonary edema, quickly progressing to severe left ventricular dysfunction and cardiogenic shock. While ventricular septal defect is another mechanical complication, acute severe mitral regurgitation primarily impairs forward flow and reduces cardiac output. Pericarditis is an inflammatory condition, and atrial fibrillation is an arrhythmia, neither of which are the most immediate life-threatening complication of acute severe mitral regurgitation. For example, if a patient suddenly becomes hypotensive, dyspneic, and develops a new, loud systolic murmur after an MI, cardiogenic shock due to mitral regurgitation should be suspected. Always recognize that acute severe valvular dysfunction post-MI can precipitate cardiogenic shock rapidly. Question 25. An unresponsive patient is admitted to the ICU, and the family arrives stating the patient has an advance directive refusing intubation. The advance directive is available. What is the nurse's most ethical initial action? A. Proceed with intubation as the patient is unstable. B. Review the advance directive with the family and physician. C. Explain to the family that the advance directive might not apply. D. Document the family's statement and continue usual care. Answer: B. Review the advance directive with the family and physician. This question highlights the importance of honoring patient autonomy through advance directives in ethical care. When an advance directive is available and its contents are known, the most ethical initial action is to review it carefully with the family and the physician to ensure that the patient's previously expressed wishes are understood and respected. Proceeding with intubation without reviewing the directive would disregard the patient's autonomy. Explaining that it might not apply or simply documenting without action is not sufficient. For example, if a patient's advance directive clearly states no intubation, the medical team must honor this, even if the patient is acutely ill, unless there's a medical reason the directive cannot be followed. Always prioritize verifying and honoring a patient's advance directive to uphold their right to self-determination.